pleasure of introducing a moderator that many of you may not know. He's very shy, reserved, quiet kind of guy. But really, it's Mark McCampbell. Yeah.
All right.
He is the opposite of all of those things. He's a wonderful gentleman, and I think it's really important to know that Mark has, before he came to Advancement Resources, he has over 30 years of experience in our industry. He has walked our walk. He has had the sleepless nights that we are all experiencing. So he knows the wounds that we all feel. But Mark is the Senior Vice President of Strategic Partnerships for Advancement Resources, and he is going to be moderating this session, How Gratitude Can Increase Patient Satisfaction and Clinician Engagement. So with that, I turn it over to Mark.
Thank you. And it's great to be here with you this morning and to also be on this platform and actually to be in this room. And, well, the bottom line is it's great to be alive at all. And I have to tell you that all of the comments about the baby boomers earlier are just fine. You know, I think that that is a group to be proud of and to be part of. And I just want to tell all the Gen Xers in the room, again, who are the Gen Xers? Because I want you to know that I'm getting stronger and staying longer. So I'm not getting out of your way. And we are here, and we're going to stay here. It is our great privilege.
That's job security of the Gen Xers.
That's right. They keep working. The opportunity that we have at Advancement Resources to work with outstanding organizations all across the United States, in Canada, in the UK, in Australia, and Singapore, you know, it's just one of the things that I kind of dreamed about doing for a long time. And to be in the place where I am now in my career and be able to work with partners like MedStar is a great privilege for me. And it's a great honor that we are invited into this. As a matter of fact, Bruce Bartoo and I were together in the Health System Philanthropy Leadership Group in AHP before I started into my life in consulting. And so now to be able to continue this partnership with Bruce is a great privilege. We are excited about helping organizations on this pathway of moving from the transactional to the transformational. And we are very excited about having the opportunity at Advancement Resources to not just be imparting information, but to truly be part of inspiration and helping organizations really see this new pathway and the new way that we have of working with our clinical leaders, our partners in healthcare, and getting the philanthropy out of the silos of being in development departments and be seen as fundraisers and really integrating that into being part of the entire organization. And that's why it's so exciting for me to be working with MedStar, because they are well on this pathway of integrating philanthropy and gratitude into the culture of the organization. So it's really a privilege to have that opportunity and see physicians particularly come forward and say, this has helped me to realize again the joy of work. This has actually brought me back to the reason I got into healthcare in the first place. And it's been said by one of the chief medical officers we have the opportunity to work with in the Pacific Northwest that this kind of work, integrating philanthropy into the culture of the organization, is the healing salve for physician burnout. So I think it's really an opportunity for us to focus on as we look at how our philanthropy leaders have the opportunity to work with our chief medical officers and our chief executives in the C-suite. And as you may be aware, the opportunity we had a couple of years ago at Advancement Resources was to partner with AHP in developing the study that talked about the CEO and CDO relationship. And I have a few copies of that on the table if anybody needs to get that. It's something I'd be happy to share with you. It's great. It's a great piece. So now it's my opportunity to introduce my partner in some very good work, Bruce Bartoo. And Bruce is a CFRE, and he's the Senior Vice President and Chief Philanthropy Officer for MedStar Health. And I'm also very pleased to introduce Dr. Stuart Levine, who is the President and Chief Medical Officer for MedStar Hospital and Senior Vice President for MedStar Health. So Bruce has been serving since 2009 as the Chief Philanthropy Officer for MedStar, and it is a regional health system with 10 hospitals in Washington, D.C. and throughout Maryland. Prior to joining MedStar, Bruce was Chief Philanthropy Officer at Mercy Health, a 40-hospital health system based in St. Louis, and then previously he served as Executive Director of Foundations for ProMedica Health System in Ohio, and Vice President for Development at Greater Baltimore Medical Center. When I do those introductions, it always sounds like, you know, Bruce couldn't hold a job, but it's actually, he's had a lot of really good experience. And of course, Dr. Stuart Levine first joined MedStar Health in 2010 as a board-certified rheumatologist. It's always good for baby boomers to know rheumatologists. And he was at MedStar Good Samaritan Hospital, and Vice Chairman of Strategic Growth and Research in the Department of Medicine at MedStar Good Samaritan and MedStar Union Memorial. And in this role, Dr. Levine was instrumental in the conception, development, and implementation of several major initiatives, including a health services research program, new inpatient medical service structure, and readmissions reduction effort. So just take a moment and thank both of these people for being here today. Dr. Levine, let me just begin by asking you to share with us that unique perspective that you have from being both the Chief Medical Officer and a Chief Executive Officer as President now of the hospital, and some of the experience and background that you bring to that.
Sure. Well, thank you. It's great to be here with everyone. You know, I thought when I was invited to sit on this panel that, you know, I was going to be unique. We all think of ourselves as unique and having unique experience. I thought, well, I'm a physician, I'm a CEO, I'm a rheumatologist. And if you've been keeping score, I'm not even the first person today that has those credentials who sat up here. So it was wonderful to meet Dr. Batchelor, to know that we are part of a very special club of people that share those credentials. But I think that that combination, right, of physician executive, physician leadership, is incredibly important. With all of the challenges we saw that we heard about at the beginning in healthcare, having physicians engaged at every level in healthcare organizations, I think, is really important, whether it's in the C-suite or not. But engaging physicians, having physicians be partners in every aspect of a healthcare organization is absolutely critical. And of course, it's critical in what everybody in this room does. And so Dr. Batchelor said, you know, she didn't think of herself as a fundraiser, and that's something that, you know, she said, oh my goodness, that can't be part of the job description. I actually learned very early in my career, coming from a very traditional academic setting. I was an academic rheumatologist at Johns Hopkins. You can't get more traditional than that. I ran an immunology lab in the Division of Rheumatology. And coming from that background, every physician, scientist, physician researcher understands that philanthropy, fundraising, telling your story, that search for the cure, that's part of the job. It's part of the job from day one. You're writing grants. You are out soliciting funds to build your programs. It's very consistent with what you're doing professionally. And for me, growing up in that academic world, it was very natural to be in front of donors or potential donors and to explain the program and paint that vision for kind of where that next investment could take the program. When I was early in my career, I was doing some very initial studies in gene expression profiling. So now we've heard about the Human Genome Project. You've heard about all of the wonderful personalized medicine things we can do. So I was on that early bandwagon, looking at some gene expression profiling for some rare disease. And I had a chip. And on that chip had 18,000 little gene fragments. And man, I could tell you what I would do with that chip, all of the diagnostics that we could do, all of the parsing of clinical information that we could use. And it was a pretty amazing story. And I could hold that thing, and I could speak to potential donors. I could speak to people who were engaged. And it was a very easy story to tell, right? Because it was holding up something tangible that I could say, if you invest in this program, think about the things we could do for patients suffering with these rare diseases that don't have a way to diagnose whether they're going to flare, that don't have a way to know if they're going to be appropriate candidates for that next latest and greatest treatment. That was a very consistent and honestly very easy story to tell. Moving from that environment into the community hospital setting, very different. What is that story? What is that hook? What is that vision? How could I talk to someone about an investment, well, in what? In providing medical care, in providing program building? Not quite as easy, but I would argue every bit as critical. And so growing up in leadership, you know, from that initial job as kind of a strategic growth vice president, well, you think about that for a community hospital, even to have such a role, well, how do we grow important community-based programs in a small community hospital? Well, it has to be through innovative clinical programs. It has to be through engagement with the community. And so linking those experiences from holding a chip with 18,000 genes in front of a potential investor to conceiving of what is the community-based version of that chip, and how can I tell a compelling story for what it is that I'm passionate about, was actually very consistent. And as I rose through leadership, both at that hospital, then as a chief medical officer at MedStar Harbor Hospital, taking on a second hospital at MedStar, a much larger one at Franklin Square, and then ultimately becoming the CEO back at Harbor, those experiences were part of kind of my leadership journey and my leadership formation. And being able to work with incredible philanthropy professionals like Bruce, like Sarah, who is here today. She left me, but it's okay. She's got on to wonderful things up in Jersey. I'm never going to disparage Jersey. My wife is from New Jersey, so we love the state. It is great. But that was always part of my leadership journey, and so something that I've become very comfortable with. And again, that hook on patient experience, on gratitude, on telling a story, on having that investment story to tell that is based in your mission and based in your community is really important. Probably way longer and too long-winded, Mark.
That's actually just spot on. And I was thinking about, as a leader in healthcare, you know, how, you know, our hair is on fire about a lot of things. And I can see that it's really taken its toll and actually taken most of our hair. But as I think about this, you know,
I'm not sure I signed up for that. I mean, really now.
We tested this earlier, by the way. So the opportunity that we have to work with leaders who understand this, that in philanthropy we actually find ourselves in a situation where we have executives and partners in the C-suite, and particularly chief medical officer, who can understand the importance of philanthropy. And I'm just wondering if this morning, is there anyone here who might be able to share an experience? And we're going to give you some time at the tables to talk amongst yourselves about your experience, but just to kind of get us started, I'm wondering if there's anyone, Donna, who might be able to help us. Here we go.
You can tell that was random also, can't you? So Mark and I talked about this a little bit earlier, and so the one of the ways that I worked to try to connect the chief medical officer at one of the hospitals in a foundation that I had responsibility for prior to moving to Chicago was to find out what his interests and passions were, what his background was, so really spend some time with him and get to know him beyond just his medical career. And then in particular in that foundation, the board members played a key role in fundraising and connecting us to the community. And so getting to know the chief medical officer and then finding connections with the board members that I knew would provide natural partnerships or natural opportunity for them to have things in common that they could begin to develop a relationship. And that proved to be extremely effective. The chief medical officer was a veteran. He liked to shoot skeet and different things like that. And I knew my board members really well, and it provided a really wonderful platform to develop a relationship that went beyond that and allowed them to introduce the chief medical officer into the community more easily. So.
Excellent example for your tabletop discussions. Now I'm going to give you 7 minutes. Please try to get around and allow everybody to share just a brief story of how you are successfully or maybe not successfully working with your executive partners Time to go now. Good job. Thank you for those great conversations at the table. Thank you. Nice work. Good. Now let's bring our conversations and bring our attention back to the center again. And as you wrap that up and refocus, I'm going to pitch to Bruce, and he's going to take us from here.
Thanks, Mark. By the way, any fans of Geico commercials in this room? Anybody know what today is? Come on, thank you. Woohoo! Yeah. I gave you guys coffee. We got to get some energy out of this room. So, is there any, by chance, are there any chief philanthropy officers in this room? Raise your hand if you're a chief philanthropy officer. So, the word philanthropy, origin, it is a Greek word. What's it mean? Anybody know? Loving. Are you sure it doesn't mean love of money? It doesn't mean love of money. But in healthcare, aren't the chief philanthropy officers financial agents? Isn't that our job? Aren't we just money people? Or maybe we're more? Maybe we're love people. That's kind of scary. Right? But if we think about our role as philanthropy leaders, and it's not really about money, that might be an end result, it's really about something else. It's about the experiences patients and families have inside our organizations. And it's why at MedStar we're so focused on gratitude, because we know gratitude is the single largest driver of significant philanthropic partnerships. And you don't have to take my word for it. Do a little bit of research. Look at the 10 biggest gifts to healthcare in the last 5 years and research how did those relationships start, right? I challenge you to find one that didn't start from a moment of gratitude around some care experience. That's what motivates people to want to be partners with us. Because healthcare, and we heard it this morning, it's a big business. It's viewed as a big business. We don't have a natural case for support. But we have a case for support when we save somebody's life. Or even if somebody's life isn't saved, but the experience is incredible, like we know happens every day in our healthcare organizations. And so when Dr. Levine and I started to do some work together, he came to MedStar not long after I came to MedStar, and we got to know one another. And we started talking about this notion that I was all about trying to build a culture of gratitude inside MedStar, because a culture of gratitude meant clinicians and caregivers understood when patients and families had great experiences that they wanted an opportunity to express their gratitude in a meaningful way. For families who are philanthropic, that expression of gratitude in a meaningful way might be a philanthropic partnership. And Dr. Levine jumped on that. Now, he had already explained great background and experience from fundraising in his time at Hopkins, but he jumped into it, and he jumped into it so deeply that Dr. Levine's been one of our physician leaders at MedStar, building a whole new care delivery model, and he's the one that embedded gratitude into the clinical training in our new delivery model. I'll let you describe that a little bit. We're so grateful that you're our partner in this.
Well, thank you. So I thought the hair joke was going to come with the notion of wearing a lot of different hats. So I would say, but you took it in a whole different direction, Mark. But one of the hats that I do wear at MedStar, from a system perspective, is that I'm the physician lead for the rollout of our new care delivery model. So it's something that, as a physician, is near and dear to me, and it's an interdisciplinary model. It brings physicians and nurses and therapists and pharmacists and the entire extended care delivery team together to care for patients in a team and geographic-based model. And many systems around the country are trying to do this, but we've wrapped that in not just as an efficiency and a financial program, which a lot of people have done, right? You want to move people through efficiently, length of stay reduction, readmission reduction. Those are important things. But we framed it actually a little more broadly. That is one of the pillars. But a more important pillar is actually patient experience. The patients will have a better experience if their care is coordinated, if their teams are talking to each other, right? You know, my favorite patient experience comment that we had from one of our patients at our hospital several years ago was actually a negative one, but I use it at every one of my leadership team meetings still to this day. The comment is, "Don't you people ever talk to each other," with 2 question marks. That was a galvanizing comment for us to say, we don't always. And if we don't always, and we're giving different messages to our patients, how in the world can we expect them to have a good experience and have good health care? But then the next layer of that is knowing how to accept the thank yous and the gratitude that we get from patients, because the reality is that most of the time we get it right. Even in our hospitals where HCAHPS scores are low, if you look at the communication with doctors domain, the communication with nurses, they're almost universally multiple percentage points higher than some of the other domains. Well, why is that? Because people trust their caregivers. They like their caregivers. Caregivers, by and large, give wonderful care. And at the end of that care delivery, even if it's for a 3-day hospitalization or a major transplant surgery, patients and families want to be able to say thank you. It's really important for them. It's part of the healing process. It's part of the overall healthcare process. And so as we were conceiving this interdisciplinary model of care, we were talking about acronyms before. Ours is IMOC. It's very catchy. It's very easy. We embedded a gratitude program and a gratitude training program for our clinicians into the core of the model. And we did that for the reasons I just said. We said, if we are going to be able to design this model that will deliver a better care experience to our patients across the care continuum, then we are going to have an avalanche of thank yous and gratitude that we're going to have to deal with. And if our physicians and our nurses and our frontline clinicians don't have the tools to accept that gratitude, know how to respond to that gratitude, we are going to diminish or potentially diminish or set ourselves up for diminishing one of those very key components of healing for our patients and families. This was brought home to me in a few ways, so if you'll indulge me, I have two stories I'd love to tell. One personal and one that I got to experience with another physician, so I'll tell the second one first. In an early training session as we rolled out this interdisciplinary model, when I was at the second hospital where I was a chief medical officer in our system, we had one of these gratitude training sessions led by a member of Bruce's team. Really, really wonderful session. And I was sitting at a table with a grizzled old neurosurgeon. So for those of you that work in healthcare systems, if you imagine what you think of as the stereotype of that type of clinician, this was that person. Incredibly talented, brilliant, took great care of patients, but was pretty gruff and pretty businesslike. And I go in, I fix it, and that's what I do. And so in the training, we were going through scenarios of actual role-play scenarios of patients or patient family members expressing gratitude. And the exercise, like the tabletop one you just, it was very simple. Doctor, how would you respond to a patient who said this? And it went something like, thank you so much for saving my mom's life. You know, what you did meant the world to us. We couldn't thank you more. You have no idea what this has meant to our family. And what do you think the response, the natural response of this particular surgeon was? Oh, please, you don't have to thank me. It's what I do. That's my job. The best, that's what I do for all my patients. Right? It's nothing. It's why I come to work every day. It's why I spent 4 years of medical school and 5 years or 8 years for a neurosurgeon of postgraduate training and residency and fellowship, spine fellowships and all the rest. It's what I do, right? I'm paid well for it. If I didn't do it well, I wouldn't be compensated. Well, he went through some version of every one of those things. And then there was a video testimonial from a patient who talks about what the impact of gratitude and the physician accepting that gratitude and what that means to them and what the expression of thanks meant to them from a healing process. And as this physician was watching this video, his eyes welled up with tears. And he said, oh my goodness. I've been doing and saying all of those things for years, and I never, ever considered the impact that might have had on patients and families. I have been so blind and so stupid. And it was this incredible thing, and he's not alone. That defines thousands of our colleagues, right? Because I went to medical school. I never learned how to accept a thank you from a patient. And the other physicians in the room, did you ever learn how to accept thanks from a patient? Right? We were told you couldn't accept a gift over a certain dollar value. You have to declare a certain thing, right? A little box of chocolates at Christmas might be okay, but a BMW certainly would not be. But we're never taught how to accept that. We just assume that, you know, we're doctors, we're good people, we know how to communicate, we have those skills. But we don't. We weren't taught that. It's gratitude programs like the one that Bruce and his colleagues have brought to MedStar that I now have the privilege of helping to bring to my physicians and my clinicians, that gives them an opportunity to interface with patients and families in a completely different way, and yes, add on that layer where they are helping the healing process. And yes, as Bruce said, for those philanthropically minded families, the next question is, doctor, I had such an incredible experience, this was amazing, what can I do to help you? Because I need to be a part of this, I want to be a part. And that might be a $5 contribution, it might be a $500,000 contribution. It's not about the money, right? It's not about the money. It's about that feeling of empowerment and investment. Second story, I'll be briefer on this one, is something that I learned. So yes, while I was having my chip and talking about gene expression profiling, I've always maintained a clinical practice. I do to this day. Monday afternoon, I saw patients all afternoon. It's something that I still do, even as CEO. It's hard, but it is critical. It is fundamental, I believe, to my being able to be successful in my job. Several years ago, I took care of an older woman with a rare disease, and we lost her. She passed away. I took care of her for several years. She came from out of state to see me. Her daughter drove her down religiously. She never missed an appointment. She was there on time, battling hours and hours of traffic to come for her 30-minute appointment. And as her disease progressed, we obviously got to know each other. We always had a little bit of laughter in the room, no matter how bad things were getting. It was always interesting to watch the dynamic between mother and daughter when mom had to admit she maybe didn't always take all the medicines as we had prescribed. But we developed a really strong relationship. When that patient passed away, we received a phone call from her daughter. So what do you think the daughter said to me on the phone? The first two words? Thank you. And I was devastated. I mean, we lost this patient, and then you, as a physician, you go back, well, did I do everything? Did I offer all the best treatments? Did I titrate that prednisone exactly right? Did I offer the right chemotherapy at the right time? And the answer is that, yeah, we did all those things, and this was just a battle we weren't going to win. But the daughter didn't just say thank you. A few weeks later, she called my assistant and said, I know that mom has passed, but I'm wondering if I can book a visit to come and see Dr. Levine and the team. Not for a clinical visit, but I'd like to book a half hour of his time because I want to talk to him. My assistant came to me and said, well, what do you think? I said, of course, you book her. So she comes in an appointment slot, and she came with a plaque that had her mom's picture, and then words of thanks from her family, and their extended community, their church, their community groups, all the groups that this woman was a part of in her local community. And it was a plaque of thanks and gratitude to me and the entire team, my assistants, our nurses, our fellows, our medical students, everyone who had taken care of this patient, to say that the time that my mom spent with you and your team were among the most joyful of her life. She looked forward to those visits, and beyond the medicine and the prescriptions and the visiting in the hospital, it was those human connections that she cherished so much that enriched her life. And because of that, we have gotten together as a community, and we want to do something to support you and your center. And that community raised not a huge amount of money. It didn't matter. It wasn't about the money. She wanted to come personally to present the plaque and a check to support us in their time of greatest despair and sorrow. That ability to come and do that was part of the healing process, and she articulated that. She says, Dr. Levine, I've been looking forward to this for a few weeks since I made the appointment. Thank you for giving me the opportunity to do this. You have no idea how much better I feel now. So you talk about going from, talking about 18,000 genes on a chip to that experience. You talk about formative experiences for me and how I can do now what I do with Bruce and the team. That's the experience that for me was formative. And that's what I try to impart to the clinicians that I work with, that it's not just that it's your job. Of course it's your job. They expect quality, as our first speaker said. That's a given. But they expect humanity. They expect you to be part of their healing process, even, and I would argue especially, when things don't go the way you think they're going to go. And that message is incredibly powerful, incredibly important.
Dr. Levine, thank you so much. And from my perspective, that's the future of healthcare philanthropy. And we as leaders should be partnering with our clinicians. We're not financial agents. We're not just the money people. That's the end result. If you have a good quality and safety program inside your hospital, you get reimbursed more, right? Does anybody not know that? Is that why you do it? Does anybody think that's why we do it? Or do we do it because it's the right thing to do? So for us in philanthropy, we got to stop focusing on it's just about the money. Because that check that came with that and the family that came, it was not about the money. To them, it was about being able to express their gratitude in a meaningful way and connect. And for you, realizing that's well worth 30 minutes of your time. It's showing respect. First of all, the experience scores we got as a result of that were good, right? But secondly, now we've developed a partnership. And it was never about us. It was always about them. Mark.
Bruce, you are doing an incredible job of integrating this into the culture. And I wonder if just in the last couple of minutes you would just share with us how you've moved to where your team was your partners in philanthropy to where your team is your executive partners in the C-suite of the system.
Well, I have to tell you, as Dr. Levine and our system chief medical officer, Dr. Steve Evans, who, when Steve was appointed CMO for the system, he sort of gave a state of the state address and said, I have 3 primary objectives: quality and safety, it's new delivery of care model, and it's philanthropy. And to have a system CMO say at the outset of his tenure, that's one of my 3 most important priorities. He recognized it was never about the money. Steve's a surgeon. Many of you have seen his video because I think Advancement Resources uses it every place. He talks about getting a $5 check early in his career from a patient, and he turned it down at first. And then he realized it was so meaningful to her, he had to accept that. And it became an annual occurrence where at Christmas time she would bring him a check. It shaped him as a physician, and then he took on leadership around, this is how we should be doing philanthropy at MedStar. I'd love to take credit for it as the Chief Philanthropy Officer. Yeah, maybe it's part of my vision in assembling a team and making sure we're implementing in that way. But we never would have gotten there without nursing leadership, without physician leadership, without the CEO being willing to say, look, you have a lot of latitude and leeway to partner around patient experience. And you mentioned before around clinician burnout. It's so logical and simple. Burnout is an epidemic in this country for physicians and nurses. So just think for a second logically. When a family says thank you to a physician or nurse, do you think that would have a positive contribution to reducing burnout? Who doesn't like to be appreciated for the work that they do? And so integrating, and thank you to Dr. Levine, integrating gratitude, which by the way is not a philanthropy play, it's a patient experience objective. Integrating gratitude into IMOC training provides opportunity for our clinicians and caregivers to actually be thanked and feel good about that and be validated. And that's helping to contribute to a reduction in burnout. And we hope over a period of time to actually do a full research study to validate this. But I think, Mark, to your point, at the end of the day, great board and executive leadership around this is a really important component part. And oh, by the way, from a tactical perspective, if you look at our top gifts that come every year in philanthropy, we tie them back to gratitude. Last year, and we track every major gift, 10,000 and up, that comes into the system. We track its origin. 97% last year were gratitude driven. The original moment was a gratitude moment. We've been tracking this for several years now. We recognize that it's true. And so as we raise more money with less resources and we integrate and build a culture of gratitude, we know we're positioning ourselves for more natural philanthropic partnerships moving into the future.
Thank you, Bruce. And again, what an opportunity and privilege it is for us to work with you. Dr. Levine, thank you very much. I think a number of us in the room, and perhaps most of us in the industry, have at some point in our careers thought that we should be measured by the size of the gift or by the total dollars raised. But I tell you, I can tell you this from having reached this point of almost 40 years in philanthropy, that it is the lives that you impact, the people that you touch, that will be what defines you and how you are remembered. Thank you.
Sure.